And I am Saidul Jaman, Oppu, welcoming Dr. Laila Parvin Banu to chair the session. Dr. Laila Parvin Banu, she is Vice Chancellor of Gonoshasthaya Dialysis and also a Honorable Trust of Affordable Healthcare. Please, Madam. And now, I'm inviting Muhibullah Khandoker to present this session. In a very short, Dr. Muhibullah Khandoker is a medical doctor with international public health degree, graduated from Chittagong Medical College in 1985 and completed his MPH in 1996. He was greatly influenced by the activity of Gonoshasthaya Dialysis when he worked as a volunteer in a seminar organized on national drug policy in 1982 in Chittagong Medical College. And he visited GK first time in 1984, and after completing his internship, he, along with some his close friends, decided to work for GK and left the government job. Dr. Mohib is now working as a vice principal in the Gonoshasthaya Dialysis in the Department of Community Medicine and as also a coordinator of Gonoshasthaya Dialysis Center. So Dr. Mohib, please come to the dais.
Assalamu alaikum and a very good morning to you all. This is not a technical session. I will just try to give you some idea about my organizations, Gonoshasthaya Kendra, and its map to history to current state here, what we are here in Bangladesh now. We all know, we've got very much, what should I say, know about these pictures. These are the pictures of 1971, our liberation war struggle. At that time, peoples of Bangladesh became refugees to India, mostly in the West Bengal and Tripura region. So there in middle of the wartime, I think in the April or May, a group of young surgeons from UK, those who are working there, they came to Bangladesh and they came to the then India and want to do something. And they were very much guided by our General Osmani at that time. And they established a makeshift hospital in Tripura state, which is just next to Bangladesh. There are some pictures out of it. And Osmani, our general, the leader of one of our generals in our liberation war struggles. And these doctors established ultimately a 480-bed hospitals which are made out of bamboos and shanty houses, something like that. So after the war we win the war in December 16, 1971. Many of those doctors and volunteers, those who worked for the Bangladesh Field Hospital in 1971, most of them went back to their working place, but few of them decided to continue their work for the new country named Bangladesh, led by Dr. Zafrullah Chaudhary. The whole history started very early already. You are very much here this morning. That a piece of land first donated by some generous people of Bangladesh in Sabar area. They started the work, and the signboard is just signifies the start of the organizations with a motto that let's go to the village and let's develop the village. So this is first the pictures, the first signboard of the institutions, and later on we call it the first health center of Gonoshasthaya Kendra, which started in a tent. And then on the lower left side is the surgical operation theater of Gonoshasthaya Kendra, which was actually shifted from the war time. And at that time, Surgeon Dr. Zafrullah Chaudhary entering the operation theater to do the surgeries. And then gradually our organization started to grow small by gradually. And as it is mostly established by a group of doctors, the very first organization sets a motto as the health as one of the door or pathways to development. So when in 1972, there were shortage of everything at that time. As we are doing health workers, we are greatly in shortage of health manpower at that time. So from the experience we learned from the 1971 Independence War, we started to think about that what we can do. In 1971, it's a 480-bed hospital. There was no support staffs. There are some doctors, but there was no nurses or something like that. And experience from there, they says that it is very much easy to train women on certain healthcare activities, and which later on transferred as paramedics in Gonoshasthaya Kendra's programs. So when we first stepped Gonoshasthaya Kendra in 1974, one of the basic strategy of Gonoshasthaya Kendra is to demystify the healthcare. It was too much governed by the people like us, the doctors, at that time, and it was in a great shortage. So thinking about delegating certain activity to other people, which are basically the village women, and making them as a very good creative support staff. At the same time, we also looking into the health resources in the community. On the upper right portions, you can see that we found out that the delivery by the traditional birth attendants in the early 70s at that time. So we sit with them and then try to fix their limitations, what you call it. So we train them and try to add to their own knowledge. And then later on, we started to work on developing a new health professionals known as the paramedics. And then the training session started in early 1972. These are the bottom pictures are some of those experiences. And then the organization is started to grow. At that time, the then Prime Minister of Bangladesh, Bangabandhu Sheikh Mujibur Rahman, donated or acquired near about 20 acres of land for Gonoshasthaya Kendra. And actually, he named the organization as Gonoshasthaya Kendra and Punurvasan, Gonoshasthaya Kendra and Punurvasan Center. Later on, it became a shorter version. What it is now is the Gonoshasthaya Kendra. And the building process goes on, and we have got volunteers, the support from the community. Community came in along with our workers to clear the land. At that time, it was a bushy land. So clear all the people, and gradually we started to work on our strategy. At that time, just after the war, one of the major strategy for healthcare development is to control the population at that time, of growth of populations. The first Gonoshasthaya Kendra, with a very strong guidance from the then Prime Minister Bangabandhu Sheikh Mujibur Rahman, they started working on the voluntary vasectomy and tubectomy program at that time. Again, they face the same problem, that who is going to assist them, how we are going to take the service away from Dhaka city to remote areas at that time like Jamalpur and Sherpur and these sort of areas. So again, the questions of paramedics comes into the scenario, and these village women, very just little educated, they were trained to do tubectomy in 1973 and 74 areas. They were also trained to do give misoprostol, and also trained on doing menstrual regulations. It's so later on we continue to do our works. In 19 sorry. Coming into firstly, the visions of GK were the fate of the poor decided the future of the country. Secondly, development of the country depends on the development of women. The first example was the use of the para-professionals. Those who are the mostly women paramedics. At the same time, they are becoming para-professionals, and also women are getting much more employment. It is more than that. Second one is the resource generation as much as possible locally. Already you can see that most of the lands are donated by the local people or the rich people. The constructions were supported by the people. When we started working in the health sector in 1974, we introduced the social class-based health insurance system in GK area. At that time, they are working in a 4 or 5 union. And another major component was the involvement of the community. The Gonoshasthaya Kendra, wherever it works from the very early onset, anywhere we go, we stay in the community and we do our work staying in the community. So later on, by 74 and 74, 75, already the international publication started coming with the experience of paraprofessionals. The Daily Mirror at that time, the British news, they say it's the L-plate surgeon. It's a sort of learner surgeons. They give the pictures of a health worker who are just trained and giving the experience. There were 2 journals later on published in Lancet. It was given in the library. And then gradually, after having acquiring a good knowledge of experience in primary healthcare, Gonoshasthaya Kendra becomes one of the pilot project or one of the pilot project of the Alma Ata Declaration of 1978. It was known as the Savar project. This is the document of the Alma Ata Declarations, and it was one of their activity in primary healthcare were recognized and recommended by the Alma Ata Declaration. As our time passes, Gonoshasthaya Kendra people started to think about that one of the major expenditure for the healthcare is the medicine, and related to medicine, it was almost at that time not available. The quality was not that much, and it was very much controlled by the multinational companies. In 1981, Gonoshasthaya Kendra decided to establish a pharmaceutical industry called Gonoshasthaya Pharmaceuticals Limited. And it was later on, from the experience of doing that, Gonoshasthaya Kendra became instrumental in the 1982 essential drug policies, known as one of the most pro-people acclaimed health policies of the world. And so later on, the organization from piloting stage expanded to all over Bangladesh. So from our experience in primary healthcare, we gradually completed the piloting phase, and then we go to the replication phase, going into different areas of Bangladesh. And later on, we started to strengthen our secondary care activities. As we are passing through, we become, getting the experience of privatizations and globalizations gradually in our programs. And GK started thinking about how to handle privatizations and globalizations. One of the steps they first taken is establishing essential drug policies, which produce generic drugs, which produce quality drugs at a very low cost, and which was very much replicated in our national drug policies. And health program, using the paraprofessionals, using of community health insurance, and using of community involvement, and as a whole, developing an integrated approach to healthcare was gradually maturing. So in mid-90s, Gonoshasthaya Kendra, in 90s actually, Gonoshasthaya Kendra also involved in the national health policies of Bangladesh, but that was not accepted and dropped later on. So now we are standing here. These are the just symbolic pictures we have. This is Gonoshasthaya Nagar hospitals, Gonoshasthaya hospitals in Savar. This is our university, Gono University in Savar, and our pharmaceuticals building. Just to give a brief short about Gonoshasthaya Dialysis Center. You're going to hear lots of technical. I am just giving you the little background. This is the Gonoshasthaya Dialysis Center is a project of Affordable Healthcare Trust. It's a charitable trust established between BRAC, Gonoshasthaya Kendra, and Grameen Kalyan. They initiated the program, and we started in May 2017. We have got 100 units. Actually, technically, we have got 110 units. So 10 machines always stay as a backup support. So now we have 53 hepatitis negative bed, hepatitis C positive bed 41, hepatitis B positive 6, and we're going to integrated ICU of 5 units. All these floors are completely separate, stays in a different floors, and whole setup was designed and developed by our chief technical at the guidance of our chief technical officer, chief technical advisor, Dr. Tawqir Karim from USA. Later on, so we gradually develop and guided by people's, Dr. Tawqir Karim coming up to here, looking into our quality always, and we develop a very good and strong QC team here, added by Professor Muhibullah Rahman, the then head of ICDDRB laboratory here, and very strong community, very strong quality issues is a part of routine procedure. At the same time, there is another pictures on the bottom right. These organizations, besides support from Gonoshasthaya Kendra, BRAC, and Gramin Kalyan, it was basically helped by lots of rich people of Bangladesh who donated generously for the dialysis center in Bangladesh. One of them is a very shy people, don't want to give his pictures, but he is who is USA-based petrochemical engineers who donated almost a big amount of money. Every year he comes and donates us money. So this is the statistics of what we have done this year up to September. We have done 66,578 dialysis sessions. As I already told you, it's based on a socio-economic class base. The ultra poor, lower middle class, and upper class. There is a rich class, but it is we don't lucky to get enough rich people here, so it's not there. So you can see here that most of the majority of our people belongs to poor and lower class and ultra poor. 67% of 37% of our patients are female, 63% are male. So our 2 dialysis sessions per week is around 61%. As you all know, I'm not going to detail, one of the major barrier for continuing dialysis care is the financial situation. Even we are providing, even our charges are very, sorry. These are the rates we have in Gonoshasthaya Dialysis Center. It's in US dollar, so I make it as because the international people said there. So these are the service charge. The 9.41 is for the ultra poor. And then gradually you can see that as people are going economically solvent, their charges getting more and more. But everyone receives the same service. There is no differentiation in service. There is no appointment system for the rich people or poor people. It is up to the receptions, and later on everyone do dialysis, whatever is possible, whatever just bed is empty on like that. And when we say the rate, this rate includes all the consumables we provide during dialysis. At the same time, we do every 1 hour blood glucose checkup. This is completely free. And during the dialysis, 4-hour dialysis sessions, any visits, any necessity of doctors and senior is completely free. You already get aware. We have got 3 full-time nephrologists working here. So if you come 7 a.m. early in the morning or 10 a.m. in the nights, you will get any of the nephrologists sitting here always. It is guided by 4 assistant registrars who are trained as an interventionalist, and at the same time 16 medical officers and junior doctors are all working here. One of the biggest problem we faced during initiation of our program is the availability of health workers or nurses or paramedics, whatever you say. So we trained as they are not available. So as we have got a very strong training program in Savar, where paramedics were trained basically for 2 years in Savar. And then we brought them here with the help of Harun Sir and Bardem. We trained our paramedics in Kidney Foundation and Bardem Fast. And later on we send them to Kolkata to Medica hospitals, where they get another 1 month's training to get much more. Later on, from 2017, they are here, and they are very much guided by our well-trained nephrologists and interventionalists. So we have done more than 200,000 dialysis sessions so far since our inceptions. So our workers now is much more skillful and trained. We are trying since last 2 years to start a courses on diploma in dialysis technology, but our repeated attempts of motivating the government policymaker is failing. So maybe in the coming days we will be succeeded. This is just give you some ideas about our income and expenditures. Income and expenditures is basically our expenditures is at 24.98 US dollars. Altogether, there are details are on there, later on below there. So we are at deficits of around $5.11 per session now. This is a direct cost. It's not include the other cost of patients coming and all these things. Plus, I also add to you certain things that although we are not, people have to pay for certain drugs like erythropoietin or other medicines. They get it very cheaper, like daclatasvir or sofosbuvir for the hepatitis C patient. We get it very, very cheap rate from the pharmaceutical industry, and also get subsidy from Gonoshasthaya Kendra. And now our Gonoshasthaya Kendra pharmaceuticals company, Gonoshasthaya Pharmaceuticals Limited, is producing all the drugs related to nephrology. We are now ready. Even hopefully by next year, we are also started to produce dialysis consumables like tubings and all these things. So just I like to finish with this slide because people are pushing me. I thought that I was the main organizer, so I will get some chances. Anyhow, this is just to give you the main motto in a very small slides. We are not a private organization. We are basically a charity organization. But charity doesn't mean that you give everything free of cost and you die after 1 hour. So one of the major question of sustainability is there. Financial sustainability is not a priority to Gonoshasthaya Kendra. Our priority is to provide services and increasing the accessibility of the people to our services and doing a very good quality services. Just bringing you these slides is that whatever is our charges, like it's in Bangla Taka. So these are the patients we have so far done this year in the 19th September. Our charges for ultra poor is 800 Taka, poor and all these things. So what we show here is how much patient is saving. We put a benchmark, average benchmark outside dialysis, GK's dialysis center to 2,000. So a patient has to survive on dialysis. So Taka is 2,000 or 3,000, it doesn't matter, they will survive. But what I like to show in these slides is how much the patient is actually saving with their getting their services in Gonoshasthaya Dialysis Center every time they come here. And so we provide even someone by the giving another example to end this up is that it's and erythropoietin is more than 1,500 Taka outside, but we are selling it here with 900 Taka. So I want to finish with these slides is actually we are saving the people because people have to do the dialysis, people have to survive on the dialysis, and we are giving back the money actually. So that is the slides I want to end because one of our major activity is the economic sustainability of our program. Thank you very much.